behavioral pediatrician, and she's a professor at the University of Colorado School of Medicine. She directs the Extraordinary Kids Clinic and the Denver Fragile X Clinic at Children's Hospital, Colorado, specializing in developmental, behavioral, and psychological features of X and Y chromosome variations. In addition to providing clinical care for extraordinary kids and their families, Dr. Tartaglia leads research on health and development in X and Y chromosome variations. And as the parent of a 26-year-old son with XXY, I'm very thankful for Dr. Tartaglia and some of the research studies my son has participated in with her. Now, Kayla is a clinical research assistant and study coordinator for the Extraordinary Babies Research Study at Children's Hospital in Colorado. She has an undergraduate in biology
increased need for genetic counselors who can counsel when the NIPS results come back positive and when there are more babies around who have the different X and Y variations. It also leads to many more infants presenting to pediatric offices for medical care and pediatricians who need to have some recommendations of what to do with all these babies. And then also infants presenting for more developmental care. It also gives us an opportunity, because there's so many more infants, it gives us opportunity to really do a lot of research and help support and understand the X and Y variations more. So it gives us a large cohort of babies that we can follow prospectively from birth to really understand what happens in these conditions. This is nice because it's less biased in terms of describing the conditions than much of our previous research that was based on, clinical samples in our clinics or even recruited samples, which is different from the distribution of characteristics that you would see in a newborn population or a prenatal population. And then it gives us opportunities to understand the family experience so we can improve genetic counseling, so we can improve medical care and developmental care for these populations. Have the sex chromosome trisomies, and there are many different either potential risk or protective factors that may influence outcomes. And so you can see here there's a lot of different things that we're looking at, thinking about what may influence some of these more longitudinal patient-centered outcomes. But our outcomes for the first 5-year grant were at the 3-year mark, looking at things like cognitive functioning, language and motor milestones, and early medical conditions, feeding, growth, body composition, and really looking at these outcomes and wanting to see, which of all of these factors over here, from race, ethnicity, socioeconomic status, different genetic factors and medical factors such as prematurity, and then other factors such as prenatal exposures, different community supports or therapies that they're getting, hormone therapies or hormone levels. Are there any of these factors that can predict these later outcomes? We are now into our second phase of funding. Just started with year 3 of our second phase of funding, and now as our babies are aging into school age, we're looking more at outcomes related to cognitive functioning, early literacy, early learning skills, and then some of the more anxiety and other social emotional aspects of development. And then the goal is to, follow these participants all the way into adulthood and be able to see how outcomes evolve over time, and then also be able to look back at which factors were predictors of these later outcomes, with the idea that if we can identify early predictors, can we then develop interventions that may change the trajectory of those who have outcomes that are more challenging. So I'm going to have Kayla tell you a little bit more about the details of the study and the participants in our study.
Hello, everyone. So I'm first going to just talk about the criteria to be enrolled in this study. So our inclusion criteria, we enrolled children as young as 6 weeks old up to 12 months old. You did have to have a prenatal identification of sex chromosome variation, a diagnostic confirmatory testing, whether that be amniocentesis before birth or confirmatory testing after birth, English or Spanish speaking. You were not eligible to be in this study if you had a previous diagnosis of a different genetic or metabolic disorder that involved neurodevelopmental or endocrine involvement, prematurity less than 34 weeks gestational age, any complex congenital malformation that was not previously associated with X and Y variations, any history of significant neonatal complications, or any known brain malformation that was identified during neuroimaging. So as far as our protocol, families that were enrolled completed 13 study visits. 5 were in person and 8 are telehealth visits. This timeline here kind of shows at which ages are telehealth and which ages are in person. Our in-person visits occur at 12 months old, 3 years old, 6, 8, and 10 years old, and the other ages are done via telehealth. At our in-person visits, the direct assessments that we do include cognitive, academic, executive functioning, language, social, and motor assessments. We also do a physical examination. We collect samples that include blood, urine, and stool, and also biobank these samples as well. Body composition, which includes the P-pod when they are infants, and then the bod-pod when they're a little bit older. And then we also do parent cognitive testing as well. Overall, our study collects information on parent and family demographics, prenatal and birth history, health history, developmental skills, any interventions and education plans, and family history. As far as our study participants, we have enrolled 372 participants. Our biggest cohort being XXY, we have 201 XXY participants. Enrollment is close, which is super exciting. Our original goal was 200 participants, and as you can see, we have exceeded that goal. Our youngest in the study is 5 months old, whereas our oldest is 9 years old. Just a breakdown of how many participants are at each study site. 114 participate at Nemours Children's Hospital, and then 258 participate at Children's Hospital in Colorado. And for this round of funding, we are funded through March of 2028. So here is just a little figure that shows the distribution of all of our participants around the United States. As you can see, everyone is kind of everywhere, and they participate at both study sites. And then just talking a little bit about the demographics in our study. As you can see in that first column there highlighted in yellow, this is all of our participants. 82.6% are white, and that isn't really much difference, but when you separate them between the trisomies. 84.7 are non-Hispanic. Again, that's not much of a difference between the trisomies when it's broken down, and 15.3% are Hispanic. And then looking at overall annual household income, about half of our participants are in the higher socioeconomic status, making over $150,000. And then just some exciting updates about our study. So far in 2025, we've had about 150 extraordinary baby study visits. This includes telehealth visits. Last year in 2024, we did about 390. Overall, we have had 12 published publications, 2 that are currently in press and 6 that are in preparation. Last year, we had 20 students and trainees working with our team and learning about X and Y variations. And this year we have 11. And as far as our professional presentations, last year we had 25, and this year so far we've had 13. So I will let Dr. Tartaglia talk about our study results and what we have found so far.
But I just want to talk through it so you can understand kind of what results I'm presenting. We talk about these participants. We've been doing this for a long time, but we started recruiting in 2018 and enrolling. And though this is the number of study participants, and this is the age they are. And if you think about it, you can't recruit everyone to start all at the same time and the same age. So when you have a longitudinal study, they're all going to have to age together, but they can't all be the same age at the same time. So if you look at the current ages, this dark blue is the first study period, and then this light 2025. So, the first baby is now older, right, up to 10 years of age, but the ones that we just recruited are still much younger. So if we want to look at an age outcome of, for example, 3 years, we have to wait until everyone has gotten to be 3 years of age. And so right now, even though we are, very far into the study at 8 years, we still have participants who are aging into the 1 year age range. So we are starting to analyze our 1 and 3 year outcomes. Unfortunately, COVID happened around, during this period of time where we missed a lot of study visits because people could not come in person. So we do have some limited data from these time periods, but we're getting there. And so, we're really proud of the cohort we have and think that, we'll continue to have a lot of rich data. So one of the papers that is in press in pediatrics, which is really exciting, is a paper that looks at all the medical care and medical problems of infants in their first year of life. So we just took the birth histories and then medical problems that had occurred by 12 months of age. And this is a big paper that includes a lot of information, but one of the things I want to highlight is our table 5 is like our big summary table of the paper that looks at medical conditions that are more common in the X and Y chromosome infants, the trisomy infants, compared to the general population. And so you can see here, these are the medical problems. So to start, some of the features that we saw that are more common in our SCT babies are infant-related breastfeeding difficulties. About 50% of our population had difficulties with breastfeeding. We saw 18.4% diagnosed with failure to thrive, sometimes very closely related to these breastfeeding difficulties early on. 33% with constipation, 25% presenting in the first year of life with allergies. This is a combination of food and formula allergies, specifically was about 20%, and then other allergies, environmental allergies or other allergies early on. As you can see, this is 2.5 times more common compared to the general population. And then eczema was also very frequent and more common in trisomy X or in XXY and XYY, the boys compared to the girls, but overall 50% with eczema. So what we also do in the paper is give a nice column of information of considerations for clinical care. So a pediatrician can look at this paper and say, okay, what should I be doing about these things? Now, all of these things are, medical problems that pediatricians deal with very frequently. They're not unique problems in pediatric care, but we're seeing them more frequently. So when a baby comes in with a trisomy diagnosis early on, they can then, the pediatrician can know what to look out for and know what to watch for. And if they are having reflux or other kinds of, problems where parents are complaining about, maybe perhaps difficulties with formula or food allergies or other concerns, then they know, oh, this is more common in this population. And so let me do more evaluation and treatment. There's not any significant differences in terms of the way pediatricians will approach the treatment of these conditions, but being aware of what happens more frequently will help lead to better care and better anticipatory guidance for families. Some of the other things that we see more commonly in the trisomy conditions is one of them is positional torticollis. We saw in 30% of our population. This is 7 times higher compared to the general population. When we look at the male genitourinary anomalies that that can be found. So this is obviously only in the male group. We saw cryptorchidism only in 3.4% of the population. This has been reported as being a little bit higher in XXY, but it was still higher than the general population, but not as high as we were expecting. Hypospadias in 1.3%. Cordy, which is a different penile abnormality, in 5.2%. And then the frequency of micropenis, which is often brought up as a potential feature of infants with XXY, was only 3.4% in our population, which was a lot lower than we expected, because this has been considered, one of the features that you often read about in the infants. So, this is not as common as is kind of in the press or in the literature as a feature of infants with XXY. We saw about 7% with strabismus or lazy eye, which is also important for following. And then in those who had echocardiograms, higher rates of cardiac septal defects, small atrial septal defects, or a small hole between the two upper chambers of the heart in the infants, which has led us to, be recommending that the infants have echocardiograms, not usually right at birth, but a few months into infancy, if they're aware, and then also increased rates of mild renal malformations. Now, most of these malformations are really mild and don't necessarily require significant follow-up, but there have been a few patients who have needed interventions, surgeries, or more close monitoring. And so this is something we're still, really wanting to understand in terms of how it might influence care. And then hypotonia or low muscle tone. And again, these are some of the recommendations that we're giving primary care providers to, do more targeted physical exams, for example, recommend physical therapy if they see torticollis, and then other things down here in terms of just recommending referrals and monitoring and exams for these differences. So this is a really important publication, and obviously we'll then go from the 12-month visit and look at then at 3 years and throughout childhood in terms of the medical problems that are presenting. When we look at developmental testing results, you can see here, I want to talk through this graph a little bit. So one of the things we do when they come in is we do direct developmental testing with them. And this shows the results of our testing so far. So this is, goes through the different domains of developmental testing that we do: cognitive or problem-solving skills, receptive and expressive language, and then fine and gross motor skills. The scores are all represented here in the different, and this is all of the conditions combined. When we look at the conditions individually, XXY compared to XYY compared to trisomy X, honestly, there are not statistically significant differences between the three trisomies, and so we do combine them all for presentation. On this graph, the red represents what would be considered in the average range. And a scaled score of anything from 7 to 13 is considered in the average range, with the scaled score of 10 being the 50th percentile. And so what you can see here is that in terms of cognitive skills, all of the groups across the age span as they get older are all falling really solidly in the average range in terms of cognitive skills. Receptive language is a little bit lower for the first couple testing assessments, but then overall is higher. These stars down here represent which ones are statistically different from the general population. So they're a little bit lower in the first couple until 12 months of age, and then fall within the average range. You can see expressive language here on average is still within the average range, but statistically lower than the general population as a group. Fine motor skills also are, right up there with cognitive skills, as, really hanging in there and being within the average range. And then gross motor skills are And then is also a poster that I'm presenting because we really want to get some input from families and other professionals about how to represent these data in a way that's more kind of family friendly and easier to understand. I want to start with just kind of explaining one of this graph a little bit, and then we can, and then you can interpret the rest of it. But in general, when we look at a milestone like first words, the black on top represents what we expect for the general population. And then the 3 bars below are the milestones and when they were achieved in our baby groups. And so the different percentiles, if anyone is in pediatrics and as old as me, there used to be a screening test that's called the Denver Developmental Screening Test. And it was a way that pediatricians could track whether or not developmental milestones were on time and if referrals should be made for further evaluation. And the way that this worked was it really plotted like how common, when should babies be achieving milestones? So if you look at first words and you say 12 months of age, first words, 25% of infants should have, and here's the percentiles up here, should have had first words by about 10 months of age. 50% by 12 months of age, 75% by 13 and a half, and then 90% by 14 and a half months of age. So the idea was anytime you're in these like the 75th percentile or below, this is a caution or a pay attention. They're achieving the milestone at the last 25th percentile compared to peers. And if you were above this, like let's say you were 16 months of age and did not have yet first words, you were really failing the achievement of this milestone. And so it meant that you should be referred for further evaluation and testing. And so what we wanted to do was plot, the achievements of our infants with the same idea compared to the general population. A lot of families will ask us, well, you say there's a risk of delays, but what does that mean? Does that mean they're not going to walk till they're 10? Or does it mean, what does it mean when you say increased risk for developmental delays? So our idea is that we want to be able to portray what that means in terms of increased risk, because some infants go on and don't have any developmental delays or, reach milestones very similarly, like we showed in the previous plots, but others, are more delayed. And so this, for example, shows that overlap with the general population, but it also shows that 90th percentile line, 75th to 90th percentile line, is a few months later in the trisomy conditions, not quite as much in trisomy X, but in XXY and XYY. But then, the 90th percentile is achieved a few months later for most. Our recommendation is still that we use the line of the general population for referrals for therapy and evaluations. We don't want to wait until, now he's, delayed for his XXY group or XYY group. We still want to use our cutoffs for the general population to get therapies and things implemented. But we also want to give a little picture of, it is the developmental milestones distribution is a few months broader than in the general population. So to show, a lot of families want to know, well, where is he compared to other kids with XXY, or where is she compared to others with trisomy X? So those were for language milestones. There's more for the motor milestones, and I'm not going to go through all of these. But again, we have it on our poster and happy to talk more about these things. And it's in preprint where you can see these online already, but coming out in pediatrics as well. The reason where these are important, right, is because speech and language skills then inform and are the basis for all of these later reading, academics, communication, conversation skills. And so, we want to really start to hit the early milestones so that these later skills that emerge from it are supported early on. And the same thing with motor skills leading to, obviously differences and later skills in terms of tasks and self-care and just physical exercise and activity. So then the next question is, so what happens, how can we predict? There's some infants who are doing really well, and then others who are having delays. And so what are the predictors? Are there things that we're seeing now that we can see them and know what's going to happen at 3? Can we predict those infants who are going to have more challenges? And so we started to really look at all of these factors in the data that we're collecting to identify those who are at highest risk. And the idea is if you can know who to target with therapies and interventions to optimize development. So what we did is we took all of the outcomes in terms of the expressive language and the gross motor scores at 36 months of age, and then we did regression looking for different variables that may be predictive of later outcomes. And we looked at demographic features, race, ethnicity, different parental education. We looked at family history. We looked at pregnancy history. We looked at birth history. We looked at different physical features at birth, if there were congenital malformations or other things. And then we also looked at developmental outcomes at year 1. Do the 12-month outcomes predict our 30? We looked at, for those that we had testosterone levels in infancy, did those testosterone levels in the XXY group predict later outcomes? And so this is a picture of those that have the distribution of scores again. Remember, you've seen this shown in different ways, but there were a proportion who had delayed expressive communication skills. And so we set that as a scaled score of 6 or below. So we're looking at what are the predictors in this cohort of our trisomy X, XXY, or XYY group that fell in this range. And what significance was that if you look at the line here, the log odds of 0, there's a lower odds of having a delayed Bailey if you're above this line, and then there's a higher odd if you were below it. So the ones that are above the line, these are correlations for and then these down here are for a more challenging outcome. So if you had the higher your scaled score was at 12 months, it predicted what was going to happen at 36 months. This doesn't seem like it would be that groundbreaking, but a lot of times in the Bailey, even in big populations, they're not predictive of each other. They're just kind of a snapshot of where they are over time. And so this, because it identifies those at 12 months who are already delayed are really a high-risk group. We shouldn't be necessarily waiting to see what happens over time. Prenatal exposures and special education and a first-degree relative were both predictors of a lower score. And Hollingshead family is a way of looking at socioeconomic status, and then ethnicity being non-Hispanic. Also risk for being non-Hispanic, we're more likely to be associated with a higher score. And so these things here, prenatal exposures, special education in the family history, are not surprising. These are things that we know are risks in the general population, and socioeconomic status and ethnicity may also be, well described in the general population as well. But these are the things that we found were important. When we look at the motor scores, there were also the Bailey 12-month gross motor score was predictive, and then special education and a premature relative or premature birth were risk factors for having lower scores. So, overall, the highlighted items here are the ones that we found were predictive of later challenges. Again, many of these are not necessarily things that are groundbreaking in the general population. We know family history of learning problems puts you at risk for learning problems, right? We know exposed to drugs or alcohol puts you at risk for having challenges, but it does identify those individuals who are at especially high risk. And like I said, the the 12-month scores being predictive of 36-month scores is really important. What we didn't find was that the testosterone levels in mini puberty were predictive at all of later developmental outcomes. So this was not statistically significant. And some of these other things like, whether or not they had gestational diabetes, whether or not they had hypoglycemia or NICU stays, these ones were not predictive, but being premature was. So in summary, these are all the things I just said. This 12-month developmental levels suggest that targeting those as a high-risk group would be really helpful. Okay, so then we're going to talk just a little bit, that we're almost out of time, but this is an analysis that Dr. Davis did, looking at what about actual testosterone treatment in infancy, because as you may know, she's already done a study that's called the Testo study, that was a nice placebo-controlled study, treating half of the infants with XXY with testosterone and the other half of the infants with placebo over time. And many of these infants in that study were also enrolled in our Extraordinary Baby study and then can be followed through 3 years of age. And so just in general, looking at our baby study cohort, this looks at 85 individuals in our study and their testosterone levels in infancy during this mini puberty period, anywhere from 1 to 3.6 months of age. And what we found was that the testosterone level on here, the gray bar is the normal range. And then this is the median for the general population. You can see that, and it is statistically significant, that the level in the XXY babies is statistically lower than the median for the general population. And there's also a larger distribution down here compared to up here. But there is, all generally within the average range testosterone levels, but as a group, lower levels compared to the general population. So there's been reports that treatment of infants with XXY leads to improved cognitive abilities later on, better reading skills, better social skills, and all of these things. And we wanted to see, does this also look like this in our study? We have all the babies in the study who were in Dr. Davis's group or received testosterone treatment. And then we have many babies in the study who did not receive testosterone treatment in infancy. And we want to see what happens over time. So we looked at many of the different possible variables between our testosterone treatment group compared to our non-testosterone treatment group. So there were 105 who had been treated with testosterone, 55 not treated with testosterone. And looking at the differences between these two groups, there were statistics index, or the socioeconomic status. So our testosterone group had higher socioeconomic status, higher likelihood of being fed by breast milk, higher rates of having speech therapy. And then we actually do direct testing of IQ in the study. And then the parents in the study had higher IQ, both moms and dads, compared to the non-testosterone group. So these are all really important factors to consider when you're looking at results, right? To be higher, you have to account and control for all of these different factors. And so when we look at the cognitive composite, if you look at the unadjusted differences, so this means not taking into account all of those factors, at 12 months of age, both at 12, 24, and 36 months of age, the testosterone treated group was 3 points higher compared to the untreated group with a p-value of 0.04. But, this was at just 12 months of age. It was not a significant difference unadjusted at 24 or 36 months of age. But however, if you did the adjusted model and you actually looked at and took into account all of those factors, there were not statistical differences between the two groups, the treated and the untreated group, at any of the time points. So from this, we conclude that, we don't think testosterone actually has an effect on the cognitive composite or on We also looked at the same thing with language outcomes and really found the same trend through all of it, was that there was a slightly significant difference if you looked at the unadjusted models, but then when you took into account the factors that were different between groups, then there was not a statistical difference over time. This was also the motor scores, the same thing. So over of these results was that the group of infants receiving testosterone had a lot of protectant features at baseline. They had many of those, higher SES, more access to therapies, more access to breast milk and other things that we know promote development, and then higher IQs of parents, which, as all of you should be very proud, your cognitive skills, are passed along to your kids just based on your baseline neural functioning and also the environment that you provide. There was not an effect of testosterone on Bailey scores or on Vineland scores. We also looked at it that way, and the trajectory in the first 3 years of life. So we did also, there are 15 individuals with XXYY in our study. It's the study recruits those with a prenatal diagnosis of a trisomy, but sometimes the NIPS test is wrong and it says, oh, you have XYY, but when they're born and we actually do genetic testing, they have discordant results and they have XXYY. So we've also included any infant who had a prenatal diagnosis of a trisomy, but later on, when they had confirmatory genetic testing, ended up having a diagnosis of a tetrasomy. And so we have 15 infants that we've followed since birth. This is the biggest cohort of a prenatally diagnosed XXYY group. And so this is really helping us understand more about XX. A big poster on all of this, but just in general, the yellow things here, we compared our XXYY cohort, this was when we only had 12, to the XXY and XYY, the other two male trisomy groups. And we saw that statistically significant differences were in all these yellow areas where basically, as we know, XXYY is more complex and has more challenges compared to the trisomy conditions in many of the different factors. So breastfeeding problems, allergies, reactive airway disease, bronchiolitis, reflux, so these things. So I encourage you to come to our poster to really look at this. And then developmentally, the XXYY are the yellow bars. And again, the mean age of different developmental milestones was statistically later in many of the milestones. So again, we know this, but this is nice evidence, and evidence that even in a prenatally identified population, we know that these kids are struggling and are at even higher risk. And so should definitely have, care. So we have lots of other projects that are ongoing and that are in the process of being analyzed and published, and looking at all sorts of things like temperament and early milestone development and executive functioning and different trajectories. And even Dr. Davis is looking at some metabolomics and other things, looking at the parent experience to really improve genetic counseling experiences. We did publish a really cool book led by Susan Howell that's called Extraordinary Babies, what you need to know when you're expecting or have a new baby. And this is a family-friendly book that has a lot of recommendations for what we've learned from the study and how to track and monitor for these. So these are available on. We're working on the Trisomy X one led by Kayla Nocon, and then XYY will come after that. And it's really hopefully to have some nice resources for families who have a prenatal diagnosis. We need money to make these books. So this is our pitch. If you're really invested in getting, new information out there for families, we are accepting donations for supporting these efforts. And then this is our little onesie we gave to all the baby in the study. Did somebody say extraordinary? And I'm happy to take a few questions.